today we have two very distinguished faculty who have not been with us. So they are the new stars for us. Dr. Nicola White, who's anesthetist and intensivist from UK. She's also the ICU tutor. And her counterpart from my alma mater, Tata Memorial Hospital, Dr. Jiggy Tewatia, who's also an anesthetist and intensivist. In addition to that, we have our older faculty members like Dr. Batra is there, and we will have Nandita is also there, and then we hope that Neil Nabar and GC Kilnani, Dr. GC Kilnani has just joined, so that is wonderful. As you know, today we have Dr. Ullas Batra moderating the first part, and then Dr. Amish Vora will moderate the second part. So without wasting much time, can I hand over to Dr. Ullas?
Sure, sir. Can I share my screen?
Yes, sir.
Okay. And just a small point, sir. Dr. Sahoo doesn't seem to be there, and his photograph also has been blank today. Any specific reason for that?
So he is busy in some other meeting, so he's not able to join us today.
Okay. Okay.
But if you saw, his name was still there. Only
yeah, I know.
His name and my name were without photograph.
Ullas to accommodate your amazing photograph, Parikh and Harini both they decided.
So Amish, you wait and see, okay? The moderation is just starting. Sir, you have disabled me from sharing my screen.
Okay. So I will ask the technical people to do the needful. Welcome, Dr. Kilnani.
Ullas, so can you try again, sir?
Yeah. Okay, I'm here.
Okay, welcome, fantastic. Neil. Okay, so all our panelists are here. We have two people from the UK, one from USA, and the rest from India. Over to you, Ullas.
Thank you. And this was the hotly debated and contested case last week where we discussed a patient of mild COVID, probably going into moderate COVID. And we had a huge discussion about whether to give steroids or not to give steroids. And 1 week has passed since then. So the score was tied at 4-4 at that time. And, 4 people said they would want to give, 4 people said they do not want to give. So my first question to everybody, which was in the previous webinar, would you still want to change? Dr. Nandita?
No, I was saying that we just want to keep a close eye on him, but not steroids at this point.
Okay. Dr. Kilnani, sir?
So my indication for starting steroids are one, that person has COVID. Second is that he has significant increase in the inflammatory markers, and my take is CRP more than 20.
Fantastic.
Of course, if there is a deoxygenation or saturation less than 94, there are no questions about it. I do not give steroids for the sake of fever. On that analogy, I also take D-dimer as the marker of inflammation rather than thrombosis. So that also I take into account. So therefore, first 5 days, generally, I do not give steroids unless there is a compelling evidence for that. But of course, we can talk about it, pros and cons of steroids. We all know about it. So
that's okay, sir. So we are still at inhalational corticosteroids. Yeah. So this was something which was not discussed. So that is what the first thing I wanted to ask, sir. If you don't want to give steroids, what about inhalational steroids? Where do you actually place the role of inhalational steroids in mild, moderate? Where do you think the role of inhalational budesonide will come? Yeah, Dr. Kilnani, sir.
Yeah. So about the inhalational steroids, India is a country where people are on a short fuse. See this 2-deoxyglucose, how it has gone into. People have gone into tizzy. Similarly, this budesonide study which came from UK with 146 patients of mild illness given budesonide, and they concluded that it reduces the severity of disease. And then everybody started giving budesonide 2 times nebulization straight away, 1 milligram, half milligram, 4 times a day, 3 times a day, and 2 times a day. And what I saw is that they developed severe fungal thrush. Oral thrush became extremely common.
Yeah.
Which of these thrush will actually give rise to candidemia later on? I have no way of knowing when you are also giving systemic steroids. And these budesonide never stops. Once started, it goes on for as long as, the prescription is not revised or whatever. So I really didn't believe that 146 patients in a randomized trial giving such a big conclusion was a good thing. But having said that, those patients who are asthmatic or have got allergic tendencies, those people who have incessant cough along with pneumonia, which is not controlled, there we always use inhaled steroids in a controlled manner, but indiscriminate. And then if you want to use budesonide for prevention of severity of, then it should be limited to the first week or 10 days, not for indefinitely. Beyond that, those people who do not have cough or do not have bronchospasm, do not have troubling cough, should not be loaded with inhaled steroids. That's my take on that.
Okay, so Dr. Batra has made a very nice point on this. A pediatrician will always tell you when not to give the drug. So Dr. Batra, your take on inhalational steroids.
Yeah, I do agree with sir. So we should be very careful in using inhalational steroids, especially in our patients, most of them who are on immunosuppressive chemotherapy and as such are vulnerable to get fungal infections, and more so in neutropenic patients too. So our stand is also the same. We are not using it routinely. Maybe we have tried only in those with mild disease who are having persistent cough in the first week of illness. That's it, and we have stopped there. Those
okay. Doctor, so if I have to summarize what Dr. Batra and Dr. Khilnani have said, mild disease, first week, NSS and cough, do not give it beyond first 7 days. Is that right? Is that, does all the panelists agree with what I'm saying? Dr. Khilnani, sir? So,
yes.
Okay, fantastic. So this is where we were. I think I have summarized the last week's discussion to not for everyone inhalational corticosteroids. And we will agree to disagree. We are still at 1:1. Some people will give steroids, some people will not give steroids. But I think this is a discussion which is still, this is okay. What is absolutely not okay is giving steroids starting from day 1. That is wrong. At day 5, day 6, you're plus minus, you're absolutely okay. Reassess the patient. But what is absolutely no is starting steroids absolutely asymptomatic from day 1. Now, let me turn to second patient, basically. She's a 61-year-old female who was diagnosed with CA breast, T2N2M0, got chemo, RT, letrozole. She has now come back with 7 days of fever and cough and breathlessness. Her respiratory rate is 32 per minute. Her SpO2 is 89% on oxygen at 15 liter per minute. It improves to 91% after adding the reservoir mask. This is the X-ray. A very easy one. I'll take it to Dr. White. So Dr. Nicola White, steroids yes, steroids no?
Oh yes, steroids for this one.
Steroids for this much, absolutely. Anyone wants to comment? Okay, what steroids? Let's start with this. What steroids would you use? I'll come to all the panelists. I'll start with you, Dr. White.
So we've been using dexamethasone, 6.6 milligrams once a day. And that seems to be very effective.
Okay, so can I ask you, what was the reason why Dexa 6 mg OD was chosen? I mean, you had to choose something. What about hydrocort, methylpred? What about these kind of steroids?
We were tending to keep the methylpred for when they were being pulsed. Also, we ran out of methylpred, so we had to use dexamethasone because we didn't have enough methylpred. Okay. I'm not sure why we didn't use hydrocortisone. I think the evidence at the time was showing that dexamethasone was very effective, so that's what we went with. Nandita, okay. do you have anything to add? You are muted,
Dr. Nandita.
Recovery trial did it with dexamethasone, and somebody has put why 6.6 because that's what is available in our ampules. So if 6 is not available for us at present in the UK or maybe in our hospital, majority of this is 6.6 and that's why it's 6.6. And we went with that mainly because of the recovery trial. I think we have used in REMAP-CAP hydrocortisone, we had used it before, but we stuck to this and we've got a protocol, what is recommended in, start, if you have to escalate, further escalation, we have got our cards, which have suggestive ways. So that's why we use Dex.
Can I ask Dr. Devatia now? Sir, sometimes when the beds were overflowing, wards were being shifted, Dexa 6 mg, the Dexa went out of stock for some time. Would I be wrong in using a solumedrol or a hydrocortisone there? And what is the protocol at your end?
Yeah, so, before the recovery trial came in, we were using methylpred. We were using 40 mg PD. So about that, roughly half to 1 milligram per kilo per day of
that's 6 mg BD of Dexa.
Yeah, that's actually much more than what we would be giving. So that 6 mg is just about 32 milligrams of methylpred. But after recovery, we've stuck to 6 milligrams of dexamethasone for most part. We are doing a trial. In fact, we've just finished enrolling in an international trial of 6 versus 12. And we'll see what that comes out to. But as of now, it's 6 milligram per kilo. But if you did not have Dexa, I guess an equivalent dose of something else would be okay. Even Visalone, if the patient's taking orally, 40 milligrams is the equivalent of 6 milligrams of dexamethasone. Even our guidelines do say that you use the equivalent dose of dexamethasone.
Okay, Dr. Batra, I am always sure the pediatricians would have read the entire thing. So, tell us the pros and cons of Dexa, the onset of action. Is it okay? And what did you use in the pediatric people?
We have used the same as sir has already described. Initially, it was done after the trial. We are using the same dose, Dexa only at in 6 mg OD, and in pediatrics we are using it at 0.1 mg per kg per dose, and in severe up to 0.2 mg per kg per dose OD.
Okay, so let me ask Dr. Neil right now.
Ullas,
Dr. Neil,
Ullas.
Dr. Amish.
Sorry.
No, most welcome. I was waiting for you to come, and Sahoo is not there. I was waiting for you to make a point. Tell me.
BMC.
I am there, huh?
You are here, Dr. Sahoo.
Welcome.
I always miss you.
BMC in 2020, 2021, from Iran there is a very good paper.
Yes.
Although it is a small number of patients, 86 patients. 86. But they did a randomized trial between methylprednisolone and dexamethasone, and they found that methylpred is better than dexamethasone. And clinically, I know Dr. Khilnani probably may throw a light on this. 2-3 COVID specialists whom I take help of in our oncology patients, they changed my prescription of dexamethasone to Medrol oral tablet in non-hospitalized patients. And both the pulmonologists have gave me the reason that in clinical practice, Medrol works better than dexamethasone. And with this Iran paper, Ullas, I would like to know, Dr. Khilnani, or maybe if you can throw some light on that.
So I can't throw much light. I'm only going to throw questions at people. So my take, before I actually went through and I saw your Iran paper, not the Iranian paper also. My teaching to the children, the residents was, if it's a mild one, F-colon 50 mg, 100 mg early. But or severe hai to Dexa. Solumedrol, we were reserving for a slightly more severe cases. That's a rule of the thumb. Maybe right, maybe wrong. So Dr. Neil, first this question to you. What about methylpred being more effective? Is it only in the WhatsApp University of Medical Sciences, or is the real one?
So just to take you back, historically, methylpred was tried first in the original SARS back in 2003. So the original trials for SARS used pulse methylpred before they used Dex or any other steroids, and that was kind of what they had tested, and it essentially showed equivalency. So moving to kind of COVID, where we are today, we're still using Dex 6 milligrams routinely. We haven't kind of moved to using pulse methylpred yet. I think the data is starting to get there. It might be something that we kind of do in the future, but right now we're still sticking to Dex 6 milligrams, and we have a couple alternative doses. We use Pred 40 or methylpred 32, but typically we just stick with Dex 6 right now.
Okay, so can I ask this to Dr. Nandita? Dexa or methylpred? Is my grading right, or is it more out of desperation to give something more?
Yeah, so in our hospital, as I said, we start with dexamethasone 6.6 IV. If we have to escalate in non-intubated patients, we give 13.2, because we found that instead of giving 6.6 BD, when we gave BD at night, they became more confused and agitated. So that's why they started giving either 13.2 milligrams IV for 7 days. In intubated patients, we've got 19.8 milligrams. That's for 7 days. Further escalation, if still not, then we every day we sit and decide, and with the respiratory physicians, we used to decide whether this patient needs methylpred. Then according to the weight, we used to give like less than 50 kg body weight, 500 milligrams, 50 to 100 kg, 750, and greater than 100 kg, 1 gram. Then cover with antimicrobial and antifungal and cyclovir as well. So that's what we did. That is our action card, which we have produced for in this patient.
Okay, it would be great, Dr. Nandita, if you can share that action card with Dr. Parikh so that he can circulate in the group also.
I will definitely
really help in the education for everyone.
This is what we have suggested, and it is a guideline. It's not a strict protocol, but we discuss each patient quite clearly with everybody. Whoever is there, 2 or 3 people are there usually.
Okay, Dr. Sahoo. Pulse dose of methylpred, the higher the better. We are medical oncologists. We don't we like dose density, we like dose intensity. 1 gram solumedrol like you used to give earlier. What about your, again in one WhatsApp group, people are commenting, do not use the Dexa 6 mg. If you have a higher level, the higher dose. Your take, sir.
Really, in the COVID time, I have not used for COVID treating any of my COVID infection beyond the prescribed dose. Okay. The Iranian trial which you showed, I just have one thing which I think others can clarify. It was a comparison between 6 milligram Dexa and 2 milligram per kg of methylpred.
Okay.
So is that the equivalent dose? That's point number 1. So if that is not, then we are just comparing 2 different things. The methylprednisolone comes into with the proposition that lung concentration is better for methylpred compared to Dexa. So I don't think that is where the confusion with the Iranian thing is. I think others need to confirm that, because we are stressing so much on the Iranian trial. So the doses are very much different. They're doubling or maybe 3 times the actual dose. So for me, I would be scared, because I do not have level 1 evidence for anything, and especially with the maker that's coming in, and steroid being one of the major factors in indicting that mucormycosis. With no level 1 or high quality evidence, I would be skeptical to use anything higher.
Okay, so can I summarize, Dr. Sahoo, by saying you will use Dexa 6 mg OD, or you will use a solumedrol or methylpred at 40 mg BD max dose? That's what
0.5 to 1 per kg. That's what.
Okay, fantastic. Dr.
Can I just add one thing? This methylpred again was mainly this came mainly from 1 or 2 teaching hospitals in our region, and because we are a district general hospital, and that was their suggestion. So that's why one of the respiratory physicians made this protocol, or the steroid protocol, for us.
Okay, Dr. Divatya, sir, how long do we give steroids? In the recovery trial, it was 5 to 10 days. A median of 7 days was given over there. Most of us, we forget to taper steroids. And at discharge, what do you do? So the people, when they're getting discharged, what do you do from there, sir?
So just before I come to your question about that Iranian trial, which everyone has been quoting, it's a single blind study. Okay, they have not told us about the strict inclusion criteria, and the long-term effects, infection rates, and so on have just not been described. So I think it reinforces some of our beliefs of some this thing about high-dose steroids and methylpred, but I think we need to take it with a pinch of salt. Okay.
So again, can I summarize? Pulse dose of methylprednate are a no-no from the group. Maybe Dexa, hydrocort, methylpred, we are absolutely okay with comparable doses. That's what we are saying.
So routine pulse dose methylpred, certainly not. Absolutely.
Yeah.
Okay.
Absolutely.
Sir, now come and tell me, sir, you have given, let's say you have given solumedrol 40 BD you were giving before. How would you taper it off?
So we would give it for about 5 to 10 days, and then we would, if the patient recovered quickly, we would stop it quickly. And if the patient recovered, say within a week or 8 to 10 days, we just stop it. But if the patient had a slightly prolonged course, then then we did sort of start tapering off after about 10 days. Then we taper rather than just abruptly stop. And the odd patient in whom we've stopped, just started and stopped after a week or 8 days, if the patient again had a slight deterioration or something, we would again restart it. But so by and large, within 7 to 10 days, we would just stop it. If we gave sometimes more because the patient received steroids even before he came to the intensive care, and it was totally exceeding more than 10 days, then we would actually start tapering off the steroids.
Okay, let's hear it from the UK group, and then Dr. White, and then we'll go to Dr. Neil. How would you give steroids? This is the most important point, for all of us who are treating COVID. How do you taper it off?
For the patients who were just getting 6.6 of Dexa once a day, then we would just stop it after 5 days. Okay. And for the patients who ended up being pulsed, we had a reducing regime for them, which was based on dexamethasone and then reducing down to 5 milligrams once a day for 5 days and then stopping it. But some patients stayed on steroids if they had we had some patients with cavitating lung lesions, or what looked like cavitating lung lesions, but were probably pneumatoceles. And so they stayed on steroids for much longer.
Dr. Neil?
Yeah, so we generally give Dex for 10 days if the patient's in the hospital, or if the patient's discharged and there's no other indications, we actually just stop it right then. We don't continue it in the outpatient, we don't taper. So that's our kind of standard practice there. For some of the more aggressive, actually, we don't really escalate steroid doses very much. We go to TOSI first.
Okay,
so
I'm coming to TOSI. I'm coming to when do you shift to TOSI at that time? Dr. Khilnani, sir, what is your take?
So my take is a little different from the group, because
that is why we are in the panel, sir.
so because as a pulmonologist, I do see a lot of patients who come back after a month with seemingly, which is pulmonary fibrosis.
Yes.
With a disability, they are unable to walk. You do a 6-minute walk test, they desaturate, and some of them have already been put by pirfenidone or nintedanib by some people. That's not what I'm talking about. The question is whether you should abruptly stop steroids because they have tied over the crisis and the patient has recovered and the life-threatening situation is not there. So now there are two issues. One is that I see a lot of patients who have ongoing inflammation going on. That means they feel unwell. Their CRP and D-dimer continues to be high, and as you reduce the steroids, the CRP goes up, and concomitantly they feel unwell also. They have fever, their appetite is gone. So these are the patients where we modulate steroids. Second thing is that we are not sure whether how to prevent pulmonary fibrosis, which is a dreadful complication of COVID. And a small proportion of patients do have disabling disease in the form of requirement of oxygen, which goes on for months together, that we have seen. So between the anti-fibrotic and the steroids, to my mind, the steroids have better effect in preventing pulmonary fibrosis. About the anti-fibrotics, we actually do not know. So therefore, those patients who have moderate or severe pneumonia, in terms of, you can talk about, there are two things. One is the score, that is a score of 10 by 25, which everybody is reciting, 15 by 25. Other thing is the morphology on the CT. We do see dense pneumonia, we do see interstitial fibrosis, where that means there's an interstitial thickening that we can see. Sometimes we are right, sometimes we are wrong, because they also tend to disappear. At that moment, we make a judgment based on the extent of pneumonia, the extent of inflammatory markers. We generally are discharging them on equivalent to 40 milligram of prednisolone or equivalent. Or dexamethasone, or and then taper it by 10 milligram every 7 days.
Okay.
We ask them to do, I'll just finish in 30 seconds, and ask them to finish monitor their sugars and give plain insulin according to all those things are standard. It's cut paste which goes on. I also want to say and add to the beginning of my comments that initially I was never using steroids without giving remdesivir, because my thinking was that steroids would add to the viremia, but I have changed my practice because it's not possible to give remdesivir to all patients because of whatever availability. So this is not a comment, but I have started giving steroids without giving remdesivir, but majority of my patients who have significant pneumonia will go on tapering dosages of steroids.
Okay, so we have three contrasting views. Some people say just take Dexa 6 mg OD for 10 days, give Tosi more, probably because they had more Tosis, and stop Dexa at 6 mg. That is what Dr. Neil said. UK view, as usual, was a moderate one in between. They have a slightly tapering dose, and Indian view, the most radical one exactly. So Dr. Devatia, sir, first you, and then Amish. How would you manage?
How would I manage the contrasting?
So I mean tapering again. Just final comments on tapering. All that. So somebody really required Tosi and required this, had a bad pneumonia with a HRCT of 18, let's say. Would you then taper off? How does it go?
Yeah. So if we've had someone who's had a very bad pneumonia, who's been on high FiO2 and high oxygen or ventilation for a long time, 2 weeks, 3 weeks, this patient would probably be on steroids anyway for a long period of time, and they would definitely have to taper them off, right? So then they would go on tapering doses of whatever, whether it was methylpred or whether it was dexamethasone or even Visilone or something, if they got onto oral things. We don't really know what produces fibrosis, what doesn't produce fibrosis, whether the pneumonia all the pneumonic areas will become fibrotic or some other areas will become fibrotic. So the field is still quite open, and there are lots of views on that. We've seen patients who received steroids for 3 weeks, 4 weeks, and still have got fibrosis. So unless someone does a good data or good study, we won't really know the right answer.
Okay.
So yeah. So, but if it's a short illness, patient gets better within a week or 10 days, I guess.
Then there is no real point of tapering it out. Fair enough. Fair enough.
But they've received steroids for a long period, definitely we would take.
So that was the WHO guidelines which I got, which said 7 to 10 days.
Ullas Sahoo. Just one thing which I do.
So can you please introduce yourself, Dr. Sahoo? Okay, go on, Dr. Sahoo.
Come on. So one thing which I do, maybe the oncologist will be takes over. Beyond 10 days, I just add a Bactrim DS as I do for leukemias. So I do it for all my patients. I don't know whether it will help or not, but I do not feel anything that's harming them. I do it for a month. That's only
I do it. I mean, Visilone 100 mg, when we give in the NHL, we do give Septran DS alternatives.
Do the Respi guys do it? That's the only thing I want to ask.
Dr. Khilani.
Respi guys don't do it.
Respi guys want.
No, we don't give cotrimexazole as a prophylactic patient because we don't. Our patients are usually come from the community as far as the COVID is concerned.
Okay.
So,
Dr. Khilani, let me just, sir, I'm so sorry to cut you short on that. So this is what the finally slide on WHO said. 6 mg of Dexa equivalent to 160 mg of Hydrocort or 40 mg of prednisolone, 32 mg of methylpred is what is recommended by the WHO. And if you think your job sucked, look at this. At least our job is much better than this. We can just sit across over there and discuss things. Okay. So now for my oncology colleagues, Dr. Amish and Dr. Sahoo and Dr. Batra would really, I want what the inputs. A 55-year-old male, NACLC, we gave Gem Carbo, cycle 2, day 8 on 1st May 2021. The counts were normal at that time. He had dry cough which was persisting with fever on 10th of May. The guy was having chronic cough before also, so that is what was going on. He called me up since he was bugging me up. I told him to do a CBC, and the report which he showed me was 7.2 HB, a TLC of 2070, ANC of 1469, platelet count of 6,000. This guy comes to my OPD. I tell him to get admitted. Since we have to admit him, we have to get a COVID test done. We also get a COVID test done, which comes as positive. His saturation on room air now is 95%. And in HRCD, the severity index score is 14/25. Dr. Amish Vora. Sir, I am asking you for this expert guidelines about this patient.
नहीं, पहले मैंने देखा pembrolizumab plus capmatinib. I thought that it has to be Ullas's patient, but then Gem
Trial
Carbo,
में
I
था,
thought
sir.
that it can be any other medical oncologist.
Now you tell me steroids, yes or no?
No, so my first point is here is HRCT scoring in patient with lung cancer can be fallacious. That is my first thing which I wanted to share.
So my take on that would be, sir, we had got a CT scan done just 2 cycles back. That's just 40 days back. So
Okay.
these changes were not there.
Okay, so you are saying these are the fresh COVID pneumonia changes, and the score is valid at 14/25. He has pancytopenia following chemotherapy, but that pancytopenia has not affected saturation as per in the room air. He's able to maintain 95% room air.
So that is the classical technique I use. You know, when my boss used to ask me questions which I didn't know an answer, read it once again. Dr. Amish, Vora, go ahead.
So answer is no steroids right now.
No steroids. Fantastic.
Unless, what are the inflammatory markers?
I'll count CRP. Okay, I'll tell you exactly. The CRP was, I made my resident write the CRP was 9.6. D-dimer was 369, ferritin was 2710, procal was 0.56.
No steroid right now.
No steroid. Dr. Sahoo, do you agree?
Yes, I would not give, I will admit definitely, but I would not give steroids for this patient. This neutropenia could be viral related. As Dr. Navni told, I have seen 2 patients in my short practice which had a non-oncology patient which had this sort of thing, but platelets were not this bad. So okay. I would wait. I would keep a close watch. That's very sure.
Okay, you would keep a close watch. Remember, this is 10th of May, I think, right? This is 10th of May, 11th of May, he got admitted. This guy, okay, what about Dr. Batra and Dr. Devatia?
Yeah, we would not start steroids, but definitely will the patient will be on a close watch under.
Yeah, patient has admitted. Fantastic. No steroids. Dr. Devatia, sir?
Probably hold off on steroid, but just maybe for a day or so. We'll see how he's progressing.
Okay. The UK group, Dr. Nandita and Dr. White.
I also feel that you just wait and watch. No need for steroids now.
Okay.
Yeah, I agree with that.
Okay. And Dr. Neil?
Yeah, also seems a little premature for steroids, would admit for sure. But
okay, we will see how it happened. Subsequently, the guy had a crashing course. I mean, you know, his saturation was 94%, 91%, 90 on 15 liters in 2 days time. His SpO2 was 90% on 15 liter per minute. The CBC showed an improvement. The D-dimers had again for 570, 9.6, 351 of this. Would anybody, and when would you consider, what now? So would you give steroids? Procal was 5.6. When would you start steroids for this patient now? Dr. Amish wants to take it?
I think, you know, the symptom, starting of symptom is just hardly still less than 5 days, right?
Less than 3 days. Yeah, so on 10th he reported to me, see, I mean, lung cancer, everybody will have cough.
No, what I'm trying to say is that still less than 5 days.
Yes.
And from mild COVID has progressed to almost severe COVID now.
Yes, sir.
If you have to look at that within 2 days.
I started steroids for him because the next day when he had 94% on 6 liter, we did started him on steroids at that time under cover of antibiotics. I did start.
You had the more, so you are telling us after 2 days, but after 1 day you started on steroids. Yes. I think there's a time where we need to think of tocilizumab or remdesivir, either of the two, because it is still less than 5 days. IL-6 351. What is the cutoff of your lab?
56 or something.
Okay, many labs have much lower cutoff.
Yeah.
So, you know, tocilizumab, maybe as Dr. Neil was talking about earlier, we can think of in this patient, D-dimer also has increased. So inflammatory markers except C-reactive protein has increased. Severe COVID, less than 5 days.
You got in between somewhere down. So did we, did all of us, as I, you know, I keep on thinking about that, did we err in not giving steroids at that time? Let's take opinions. Dr. Neil?
No, I think you have to wait until you see some more clinical deterioration in order to give the steroids, but it certainly is, you know, required now. But in terms of, I know we're talking about potentially starting TOSI, but I think you also have to watch at least for 24 hours on Dex and see if condition is worsening or staying the same on Dex before you start TOSI. So no, I don't think that you erred by not giving it before, and I think it was started appropriately, and then the TOSI judgment is made as it evolves.
Okay, and Dr. Nandita?
So I feel when the saturations were 94, you were right. My feeling is that's when we start steroids. Regarding TOSI, we have a protocol whereby we give TOSI within 48 hours of coming to critical care. That's what we had, because we had restricted this. And that's within first 48 hours. With either the use of vapotherm, or if you are using high flow nasal oxygen for these patients, and that's where we give TOSI as well.
Okay,
So,
Dr. Devatia?
In this case, I was just wondering, you were just saying that the PCT was high, right?
Come again?
You said procalcitonin is high.
No, it was normal, 0.56. It was normal.
0.56. Sorry, I thought it was 5.6.
Yeah,
okay.
yeah. Okay, Dr. Devatia?
So, yeah, I think if you started steroids the previous day, I think you were all right. I don't think you were late or
next day,
or whatever. Yeah. So 1 day prior to the slide. So yeah, so that was okay. Now the only other question is, we need to look at 2 or 3 things: whether there was progression of disease, whether there's an intrapulmonary bleed because your platelets were only 6,000, and or whether this is just a flare-up of the COVID.
Sir, I think to answer that, sir, I mean, HRCT, the radiologist refused to comment on the disease status. Patient has received carboplatin, so probably thrombocytopenia was related to the drug. We thought it was COVID, basically.
Yeah. So if you've ruled out a secondary infection, which I guess your procal is not high and your counts have not shot up significantly, because the problem is these are inflammatory markers. The D-dimers, interleukins, and your CRP are inflammatory markers, and they could go up with a secondary infection or intrapulmonary bleed or COVID. Now, if you just have reasonably confident clinically that it's none of the others and it's just COVID, I would still think that maybe you could, since you've even given just 1 day of steroid, you could still maybe wait for a day, but TOSI is definitely on the cards here.
Yeah, so that is what my next question over there to everybody was: steroids pulse, yes, no? I don't think we did. Point here is, this is what I wanted to ask, and this is what everybody in my hospital wants to ask, how long do you wait? People not responding. So this guy, I mean, my resident has made a chart, 94% on 8 liter in the morning, 94% on 10 liter in the evening, 90% on 14 liter at next day morning. Dexa 6 mg, the growing sense of wanting to do something. Do we give methylpred 40 mg BD? Do we increase that? Do we give TOSI? The house's opinion. I'll start with Dr. Batra, and then
Sorry. Yeah. So as already said and agreed upon, yes, Dexa you have already started, and after 24 hours of Dexa, the patient has deteriorated with desaturation and is on high flow oxygen. And even though the CRP is not that elevated, your IL-6 was many times elevated than the normal here. So TOSI is a considerable question here. So all the analysis and the RCTs have shown TOSI to be beneficial. The clinical scenario is the apt one. A patient deteriorating within 3 days after starting of steroids and becoming severe. That's the ideal time point of a TOSI. But again, then your inflammatory markers apart from IL-6, your CRP has not gone much high. So that is that's a contending thing there. But if you have ruled out other causes of SpO2 dropping and deterioration, as Dr. Devatia sir has already pointed out, some sort of an embolism or a pulmonary bleed, which is not the cause for this rapid deterioration, then I think you can think about TOSI at this point. So the CRP is not at the cutoff what the trials and the meta-analysis have revealed. But yes, this would be the ideal patient because later it has not shown to be of much benefit.
Okay, so you said 3 to 4 days wait. If everything is going fine, you can go ahead and give this thing. Fair enough. What about Dr. Nandita? I'll take everybody's opinion. Do you go from Dexa 6 OD to 6 BD, or do you say Dexa 6 OD BD is okay and next step is TOSI?
So we go to Dexa either BD or or 3 times, depending on how severe. So it could be that as well. So as I said, we had 13.2 or 19.8, and he's a good consideration. So if you're going to admit him at this time, high dependency unit, because then comes the decision whether afterwards we are quite strict about whom we ventilate and all those things. But if you see that, then yes, he's a candidate for TOSI, and we give it within first 48 hours of coming to critical care.
Dr. Neil?
So yeah, I think this patient probably is a candidate for TOSI at this point. So once our patients have been on steroids, Dex6 for 24 hours, if they have persistent hypoxemia, so requiring over 6 liters of O2, or they're like rapidly progressed, so they've gotten an increase in 4 liters of oxygen requirement over the past 24 hours, we are going to start TOSI at that point. So I kind of think we're kind of in that range. Yeah.
Fantastic. Dr. Kinani, sir, you always have the last word.
No, please, sorry. It's not like this, but I would plead my inexperience in treating many patients who have oncologic problem and have come out with this kind of IL-6 and CRP. In my practice, CRP is always raised. So I just want to put across point that although the CRP of 75 has been taken as cutoff, I do not take it as sacrosanct. I take the whole picture into consideration in the severity of illness. And of course, oxygen desaturation is the most important, and other parameters are also important. So CRP 9.6 is too low for me to consider tocilizumab, but I always, and again pleading my inexperience with oncology patients, I would think that very few things are proven in COVID care, and tocilizumab is one which has got proven. So I would use it. Thank you.
So we did give tocilizumab to this patient, and the patient unfortunately did not respond. He's still battling it out, still on steroids. So let's see how it goes actually. Yeah, Dr.
Can I ask one thing?
Yeah, sure.
You give a second dose if first dose.
So we did want to give a second dose. They were not willing. We did try to tell them after 3 days we could not get TOSI. They were not willing for that.
But I guess he was on remdesivir.
He was initially yes on remdesivir. Yeah. Dr. Devatya, you have a point, sir.
No, so I was just going to ask you, Dr. Ullas, what was his white cell count when you gave the TOSI?
White cell count had recovered, sir. White cell count was around 6,000, and all the hematological parameters had recovered by that time, sir.
Because in the early days when we gave TOSI to patients with these borderline counts of 3,000, I know 3,000 is not borderline for oncologists, but when they're just recovering from chemotherapy and their counts around 3,000 or around that range, and you give them TOSI, some of them actually did worse. They did.
No, the counts had recovered at that time. So that was a dilemma actually. Cancer, chemotherapy, COVID, and I don't know what to do, what not to do actually. So
Ullas, there's a simple query. This condition is apt for a TOSI probably. You're right on that. But only thing which I wanted to get experience of others, I've used only 3 TOSI, and all my TOSI patients had elevated CRP, not maybe 75, but 40, 50, 80, and a clinical condition consistent. What the others with more experience, do they find this low a CRP fitting with a cytokine storm? Although we know that nothing is a more 100% predictive, but this is too low a CRP value. So just quick comment, because the recovery trial, which is positive, had a 75. The UK trial, I'm not sure of whether they took CRP as inclusion, which I think they did not. They did not. So a quick comment.
Dr. Neil, can you comment on that? Since you have the highest TOSI easily available over there. You're muted, Dr. Neil.
Yeah, we actually, again, we don't have a hard cutoff for CRP for TOSI, and kind of take it in with the rest of the clinical picture. And if it looks like this patient is deteriorating and we clinically think it's kind of in line with the time course of cytokine storm, we're going to give it regardless of the CRP.
Okay. Dr. Devatya.
Yeah. So, this CRP has various values in various labs. Now in the recovery trial, I think the normal was 10 and 75 was the cutoff. Having said that, the median CRP in the recovery trial was 140. So it was actually much higher than what was required for inclusion. The MapCap did not look at CRP. The thing about IL-6 levels is, you need to be careful about how they are collected, and apparently a lot of significant pre-analytical error by the time it goes to labs and comes back, maybe, depending on where you do it and that sort of thing. So because the IL-6 of is so high, it is not very consistent with a CRP of just 9.6. So, but I guess the overall clinical picture is more important.
We blamed it on chemotherapy. So, in chemotherapy, anything can happen. Dr. Khilani, sir, you have a point.
No, I just want to, just whatever Dr. Devati has said, he is the best person in that. And in my practice, even in OPD practice, everybody is getting IL-6. And it has absolutely no correlation with the clinical. It is most unpredictable parameter in this COVID times, although it's most fancy at the same time. Similarly, the D-dimer is also, if you keep the sample for 2-3 hours, it's lying on the table, we find out that it goes to 3,000. Second day you do 500. But it boils down to the fact that CRP remains the most reliable parameter as an inflammatory marker. And another thing which I found out in a non-oncological practice is the lymphocyte count. So many of my patients with severe COVID have lymphocyte percentage of 2%, 1%, and 0 eosinophil count. And this is also happening in the subacute and chronic phase when they have smoldering inflammation. The lymphocyte count goes down and eosinophils count becomes 0. This is not the talk, but I just thought I'll put across. Thank you.
Sure, sir. And so we thought our job is difficult. Think about this guy. I'm sure our job is much more, but I think in this case, our job was slightly more difficult. Okay, let's go on. I think this discussion will go on. One more case of cancer and COVID. So this guy was a metastatic small cell CAUB, and he had an obstructive hydronephrosis, got 1 cycle of etocarb, had COVID, day 6 of symptom, had chest pain, breathlessness. The ECG done showed a slight bit of inferior wall lead 2-3 AVF elevation. Property was positive. His SpO2 was 92% at 3 liters of oxygen with worsening oxygen requirement. This was the X-ray. So, Dr. Amish, sir, steroid, yes or no? So, inferior.
Having myocarditis or a pancarditis type of picture.
Property was positive.
Property was positive. So that's what I'm saying, that so there's a proper cytokine storm involving heart and lungs both. And definitely I would give steroids, because day 5 you said there was a worsening. So today, yes. Day 6 or day 7, we are justified in giving steroids. But as did you give any antiviral to this patient?
This patient was on remdesivir before, yes. Anybody who was unmuted?
We should start steroids and also take a cardiology opinion also in this patient.
Okay. Dr. Neil?
Yeah, I think I want cardiology's opinion first, but also probably would start steroids. Kind of agree with everything Dr. Vora just said.
Okay, Dr. Nicola White.
Can you just go back to the previous slide for me?
Sure. Here we go.
Yeah, no, I wouldn't start steroids at the moment. It's too much of a mixed picture, and the X-ray doesn't fit. So yeah, I agree. I get cardiology involved.
The cardiologist says, manage conservatively from the cardiac point of view, rest as per the COVID physician. And that's a classical statement, which everybody says.
Yeah, they'd say that with us as well.
Ultimately, you are the guy who gets caught over there. You're the consultant has to take that call. So Dr. Nandita wants to make a point.
Oh, no, I was just thinking, yes, cardiologists don't. I know what happens with the cardiology coming in to an opinion in the COVID ward. But the other thing is, I would discuss, I think, with the respiratory, with SATs at 92 at 3 liters, possibly my inclination is possibly yes to go and start steroids. But the other thing is, I would discuss with the oncologists or the thing as well, because they are the ones who give us all, you are the ones who give us all the help. And that's what we do in our hospital. We have a joint decision made.
Yeah, Dr. Amish has a point.
Ullas, I wanted to, of course, just for 30 seconds, I wanted to snatch your role and ask Dr. Nicola, the worsening hypoxia and myocardial injury in terms of TROP-T positive is very evident in this patient. We don't have inflammatory markers, but probably looks like cytokine storm. What is a contraindication of steroids? Because you categorically said you would not start steroid on this patient. So I wanted to understand why.
We tried not to start steroids too early. So in terms of his hypoxia, it's not really bad enough at the moment. You know, I think this is one of the ones that we would sit and have a discussion with. We were very lucky at the time that we would get together with our respiratory colleagues every day and sit and discuss these type of complicated patients and the best management for it. To be honest, his saturations aren't bad enough, and that sounds awful, but it depends on how quickly he's worsening.
On oxygen, SpO2 is 92%. Where would you put this patient, in moderate and severe?
I mean, I would he would have been looked after on our respiratory ward rather than in the high dependency unit. In fact, eventually he would have been looked after on just an ordinary medical ward. So we didn't start patients requiring that small amount of oxygen on steroids until they kind of hit the respiratory ward or the HDU.
So if this patient is on remdesivir and on, say, second or third day, this is the picture, you would continue remdesivir and not start steroids. Is that the right thing, what you are saying?
I think I would have a discussion about whether or not it would benefit him starting steroids, and he would be one of those that's...
Sure, Dr. Kenani, sir? Dr. Sahoo, Dr. Kenani?
No, just before he answers, just simple point. In such a confusion, now with baricitinib being coming in and steroids not to be given, where do the other intensivist or even freelancer put this drug, especially with remdesivir ongoing in this patient?
So can you show go back to the X-ray?
Sir. Okay, here we go.
Yeah, okay, all right. So if you look at this X-ray, nobody has doubt that he has pneumonia.
So
unilateral shadow, consolidation, it's not fluid overload, he doesn't have a low ejection fraction. So if you see the meta-analysis of pneumonia in steroids, irrespective of the etiology of the pneumonia, in severe pneumonia, steroids have role, whether corona or no corona. So you have to think whether you are treating a respiratory condition primary or you are treating a cardiac condition. And everybody has said that you will refer to the respiratory physician, so I am there for you, if you talk about the respiratory. So if I was to treat this patient, my take is that this patient has pneumonia, COVID or non-COVID. This patient has hypoxemia. I have absolutely no doubt in my mind that I'll put him on steroids, and I've already given the reason for that.
So the point here is that if he has a ongoing MI also with that, I mean, that's the point. Will it not have a effect on the myocardial injury? That's the point.
The risk and benefit.
Yeah.
Risk of steroids with
in
myocardium, acute MI. If you remember, I'm a little older than you.
So not little, sir. Not little, sir.
When I was doing MD, steroids were given in acute myocardial infarction. It was thought that myocardial infarction is an inflammatory disease. So what I'm trying to say is that it won't cause too much harm if it was a myocardial infarction. But the fact of the matter is a pneumonia. What is not questionable that there's a pneumonia, there's the COVID times where the COVID pneumonia, in any kind of pneumonia, then this meta-analysis says, and I can give you the reference, that steroids leads to better outcome in severe pneumonia. And that's my take on giving steroids in this patient.
Okay. Dr. Sahoo, you had a point, or can we move on to the next one?
No, move on.
Okay. I think we'll just go on. I had one more case. Okay. Any choice of steroids in this particular patient? Do you think we should give Efcorlin, I mean, Hydrocort or Dexa or methylpred? Is there a difference? to, or anything is okay. Dr. Neil?
For the palm guy here. I don't think so though. Difference.
Okay, Dr. Batra is given her final pediatric comment that, we can start 6 mg OD. So we did start him on, this patient was given steroids actually, I am not going to discuss one more steroid. I think we're just going to go to the mucor. So this is a WhatsApp message which actually came, this is a WhatsApp forward actually. Everybody would have seen, So this guy feels that there is something in the teeth over there. So this lady calls up, and this lady is aptly named as hyper patient. So they said, I think I'm having fungus over here. So this guy says, did you have a poha or something in the morning? They said, yes, just take that out. So mucor, I mean, for all the respiratory physicians and the oncologists, steroids, Dr. Bapsi was my boss, is my boss, and she told me steroids are the single most important things for an oncologist. We give so much of steroids, for BEP you give 56 mg of Dexa for 12 weeks. For NHL you give, for ALL you give. Where was mucormycosis all these years? Where was mucormycosis in the first wave? Why is it that, mucormycosis has come over here? I'll start from Neil first. Neil, did you see so much of mucor in US and in the whatever waves you guys had?
No, not really. It's not something that we have seen much of. We've had other obviously other fungal infections in the context of steroids, but no, I haven't seen mucor at all. So
not from us as well, Ullas. We haven't seen any mucor, and we would like to learn from you all about mucor and treatment, because I see, if you've not seen it, we've just reading various things. People who've actually seen it and treated it, you can enlighten us. I think the same
Dr.
comes from Nikki, right?
Dr. Batra has put her hands up and said that she would like to enlighten us.
So for our ALL patients with steroids, and especially those who are on Dexa-based induction or reinduction, especially during induction period, where together with the steroids, the T cell, all the immunity are suppressed, we do have a few cases of mucormycosis, and we often, at one point of time, we do have one patient who has mucor and is on liposomal ampho for that matter. And it's very difficult to do that. So maybe it's related to the Dexa, not the appropriate dose and duration of usage of Dexa, that mucor is so much come in the COVID period.
Dr. Batra, I mean, even if you style in mild COVID for everyone, 60 mg of Dexa over 10 days, I don't know. I mean,
so there might be the COVID viral infection induced immunosuppression also may be contributory to that to an extent. And if you look at it, there are many people who are getting steroids for longer duration, 2 months, 3 months, and at a higher dose too.
Okay, Dr. Sahoo, and then Dr. Chetan.
This could be because of the T cell suppression more predominantly. That was my feeling. But I have a simple question, which I still doubt the number of cases being reported. Are all of them being histopathologically confirmed? That is the only way how you can do a mucormycosis diagnosis. So the cases would be there, but I think there is something, a catch in this. The numbers are too high suddenly for us to believe. It never happened in first wave also. So has the virus just mutated enough to suppress the T cell much more? There's something which I'm looking at very differently.
Okay, Dr. Chetan has a point. Dr. Chetan, can you?
Yeah. So basically, we, as Batra said, we have one or two patients at any given point of time who have mucormycosis. But what we have seen is that these patients have been having prolonged neutropenia. They are being on steroids. And another thing is that if you see the Mumbai environment is such that it is humid, and that is where I think we get a lot of mucor. But our fellows who have graduated from here and gone to places like Bangalore, they say that they don't see as much mucor as they, or aspergillus for that matter, as they have seen, as much as they have seen in Mumbai. So actually the weather also matters, I think. And if there is, of course, we know that if there is a construction, you definitely see more of aspergillus. So I think those are some of the things that we should also consider. So prolonged neutropenia and heavy dose steroids for a prolonged period of time.
Dr. Khilani, sir, your take. on mucor?
So,
Hype or reality or whatever it is?
No, it's a reality. There's no question of hype. It's a fatal disease with a high fatality rate. My thinking is that the culprit is abuse of steroids with a total disregard to the blood sugar levels, and that is happening. People with on steroids not being monitored for sugar, diabetes going. I mean, all our patients who are 50 plus who were given steroids, either they were diabetics from before or they developed impaired glucose tolerance after they got admitted. That seems to be the most important. Denominator is too big. That is also you should understand. Denominator is too big, and once the mucor occurs and it goes into the advanced case, the mortality is extremely high. So it is not that I don't think something has happened. The surge is too big. The steroids have been abused, as we have talked about. We all have seen dosages of 8 milligram dexamethasone 3 times a day from day one, and people have given astronomical dosages of steroids. So that has led to this mucormycosis, and awareness has come. That's about it.
Okay, so steroids, uncontrolled steroids, uncontrolled diabetes.
Yeah. I'm not boasting anything, but we are a COVID hospital with 200 beds. I haven't seen a case till now.
You haven't?
I haven't seen.
Even in RGCI, sir, I haven't spoke to my infectious guy, but at least in our patients in the last, whatever patient 250, 260, we haven't seen a case of mucor. So I don't know.
Yeah.
Dr. Amish?
We too haven't seen any.
Each our patients, irrespective of whether he's a diabetes, doesn't have diabetes, if he goes on tapering doses of steroids, there's a standard, cut paste, this thing that if your sugars are 150, 200, this much insulin, that's standard of care. So what I'm trying to, that if you keep sugars under reasonable control, not the tight control, mucor is very unlikely.
Okay, Sahoo, Dr. Sahoo?
Sorry, my point is very clear. We have been giving to, ours is a subgroup where we have always been seeing patients with higher doses of steroid for longer duration steroids. And mucor I've seen only 1 or 2 cases in the whole career of 15, 20 years. So point is, I still have a doubt, is all those mucormycosis being confirmed histopathology? Okay. So Dr. I feel there is a component.
Fair. Dr. Devatia?
Yeah, so I'm as puzzled as you are with this incident of mucor. We haven't seen, like Batra said, in pediatric patients. We've not seen in the ICU with the COVID patients, nor I just checked with the oncologists on the wards when they're treating the COVID patients. They've not seen mucor either. And I'm just wondering where Aspergillus has got in all this. And, and of course, the other sort of infections, the secondary bacterial infections and all those sort of things. So I'm quite puzzled. I'm sure poor blood sugar control has got a lot to do with it, because most patients are being managed in poorly, in these jumbo centers and these COVID hospitals that have come up in a very short period of time, where there's not enough time or attention to do frequent blood sugar measurements and adjust the doses of insulin. Most patients are just taking the usual doses of oral hypoglycemics while they're getting pumped with steroids, like Dr. Kilnani pointed out. We have heard anecdotally about patients who are non-COVID, who are non-diabetic, and who are COVID negative, who had mucor. So I really don't know what's happening, and I don't think we've got enough information on what exactly is happening. Though we all suspect steroids, diabetes control, and also heavy use of antibiotics, especially in the community.
The cocktail of medication that everybody is getting. So I think, steroids is good, but it has to be handled properly with a good monitoring of sugar, and not in everyone. That is what I think the take-home messages from the panel is going to be there. Dr. Amish.
So, I see, like you said, RGCI, PSRI, Tata Hospital have not seen a single case of mucor. In our practice in oncology, if we would have seen 100 cases of aspergillosis, we would see 1 case of mucormycosis. And as Tarini said, I have seen 4 cases of mucor in my oncology career. All 4 have died. Okay, so I think images, if there are biopsy proven mucormycosis floating around in India, we are missing some link here. It is not as simple as steroids and as simple as uncontrolled diabetes. Either abuse of antibiotics or, as Dr. Roshni has mentioned, probably something to do with humidification of oxygen or some alteration. We are missing some point here. It is not as simple. Nobody has seen mucor. We have given so many immunosuppressants in our career. So it is some link is missing here. We still need to understand.
Ullas, can I come in?
So you are the boss. Last I heard.
So there is one idea that is floating around is that is it because we are now using oxygen cylinders meant for industrial use? So when you have an oxygen cylinder that is for medicinal use, the quality assurance and control is much different. And is it that the spores are actually contaminating the oxygen cylinders, and that is what we are giving to our patients? So that was the point I wanted.
Okay, Dr. Navneet has a point.
Yeah, so we've been seeing mucor, I mean, over the years, because we have, it's our pulmonology unit. So typically earlier it used to be just post-renal transplant, triple immunosuppression. But over the years, we have had just uncontrolled diabetics presenting with pulmonary mucor. And they have all been proven by FNA or biopsy. And some of them luckily got treated with just medical management, although the recommendation is surgical treatment along with medical. So the COVID, post-COVID mucor is real. I think right now in PGI, we have close to 5% of the patients. I am not sure. It's just based upon some data which I looked at somewhere. So it's probably 5% or less who have that. And the four factors operating are very clear. So you have steroids being used, you have antibacterials high-end being used, you have additional immunosuppression being used, and you have had people who are either diabetics or developed diabetes, and the sugar control hasn't been proper. So these four factors are good enough for mucor to develop. And plus you may have role with the ambient air and other factors which are operating. I don't know, as Dr. Purvish said, perhaps something to do with the oxygen and all that. So it is there and it is important. So it's just a matter of fact that it's been diagnosed at some places and not been diagnosed at others.
Okay. Dr. Kinani has a point.
No, I don't have a very solid point, but we have
always have a solid point, sir.
No. I have been wondering, the what, and as Dr. Parikh brought out a very, very important offbeat point. I have a point. Nowadays people are using very dirty masks, all the time. The masks are never washed. I'm not talking about healthcare workers in the outside. I think that should also be considered as one of the factors which will give rise to fungal infections in COVID times. And mucor, I know, is a ubiquitous organism, nevertheless, but this should be considered as one of the reasons for escalation of mucor in these patients.
Totally agree, sir. Yeah.
That's true that. So I think since I
Ullas,
have
just 1 second. The only thing we should consider, because none of our US colleagues and UK colleagues have seen that, is something that is unique, what we do, what they do. That could be the only factor that could lead to us something where we are.
I think Dr. Kelani and Dr. Parikh have made important points, Dr. Sahoo, regarding the oxygen cylinders, the masks that are worn, and in addition to
that's exactly what I was pointing out. Now, the virus is not the culprit, maybe the difference of management and how we do it. And 5% for Navneet is something that's very hard to believe. It's too high.
Okay, so last 10 minutes before I have again taken up Amish's time today. So I'll finish off my moderation this time. Oxygen in the setting of COVID, my first reactions was, this is what my daughter told, when I said the oxygen cylinders were not there, she said, but Dad, oxygen is there all in the environment, take from there. So it was like water everywhere, not a drop to drink. So what is the problem? Dr. Batra, oxygen, what was the problem? Was it the production, the demand, the storage, the transport? You are muted, Dr. Batra. Can you unmute yourself, please?
Yeah. So I think in the setting of in this overwhelming COVID infection during this pandemic, I think all of this has contributed to the decrease in the oxygen availability, and that has played a great problem in the initial part of the pandemic. And now I guess everything is there. We have less plants producing medical use oxygen. We never had this so much demand of oxygen at any point of time in a given hospital or in a given clinical setting. So I think it's just overwhelming, and there has been use of oxygen even in, and given that we had these all restraints, we had there have been use of oxygen even in mild cases. The day you are diagnosed with COVID, everything has added your higher threshold of SpO2 less than 95, 96. So in this deficiency period also, we have there have been usage of oxygen even above the threshold what is advised. So all of this has and yeah, and also many a times there is this direct transition to the non-rebreathing mask without using a face mask or a nasal cannula. So you need at least 13 liters, 10 to 13 liters to blow up that NRM. Many patients don't require that much of 90% FiO2 in the upfront setting also.
That is what I wanted to ask Dr. Devatia. Sir, you know, I mean, directly to go to Venturi, I mean, just a quick 2-minute refresher course in the delivery system. You know, I read this after a long time, back to my MBBS days. When to use which mask?
So it depends on how much oxygen you need. I mean, if you can make do with just 2 to 3 liters of oxygen to maintain your SATs, and again, your oxygen targets, you know, we can sort of rise a little downwards. If the patient is well monitored and is conscious, I think even about 92% saturation is okay if he's well in a well monitored area. So if he can maintain that on just 2 to 3 liters, it just needs a nasal prong. Then you can go on to a face mask. And essentially, I mean, if you require a higher flow of oxygen, more than 10 liters, then you do need a non-rebreather. Okay. Venti mask is, you know, it gives you a fixed concentration of oxygen, but it doesn't really save on oxygen because you still need a certain flow to go through the Venturi device before you get that desired O2. And the higher the FiO2 oxygen concentration you need, the more flow of oxygen you're going to require. But only gives you a more sort of reasonable guarantee that you're getting the oxygen concentration that you want. Now, the big controversy is whether you should give high flow nasal oxygen, you know, where you give 60 liters per flow, or whether you should go to these BiPAP devices. Yeah. Now, the BiPAP and the CPAP device are also okay if they are the simple portable BiPAP, which, you know, many of the obstructive sleep apnea or some of the COPD patients use, where you enrich oxygen via flow meter, right? So they don't require a hell of a lot of oxygen, because then, but the maximum amount of oxygen concentration you can achieve is around 50 or 60%, maybe not much more than that. So if the patient needs more than that, you then need to go to a ventilator. If you give a high flow, now it'll be a little technical, but some ventilators, when you give non-invasive ventilation, if they have flow compensation, if there's a leak and the flow compensation is significant and you get flow rates of almost 80-100 liters per minute, then if you're giving 60 liters, 60% oxygen, you're still consuming a lot of oxygen.
Yes.
So you need to take everything in context and not have a blanket ban on high flow nasal oxygen. Oh, it consumes too much oxygen. If you're giving a 50 liter per minute flow and 40% oxygen, you're consuming much less oxygen than giving a non-invasive ventilation with a flow rate of 100 and 60% oxygen. So, you know, I don't want to get into that.
No, that's okay,
problem.
sir. But I honestly, you know, when I was preparing for this moderation, I actually read about what mask to use at what concentration, what flow is very, very important. I would request all the people who are treating COVID, and even when we go back to our oncology things, to actually read that once again and use the mask in a proper way. So thank you for that. And last question to Dr. Amish. Amish, you were in Delhi. I think you surely were not connected to Khan Chacha. But you did, you know, help people in getting oxygen cylinders or concentrator. Which one for whom?
So there was no point in selecting anything, Ullas. At the peak of the time, nothing was available.
Yeah.
But what I felt was oxygen concentrators which were available, many of them did not produce the results which we desired out of the book or the pack insert booklet which came along with oxygen concentrator. So as a result, slowly from oxygen concentrator, I started telling people that oxygen cylinder would be a better choice rather than oxygen concentrator if you are not getting the bed. That is what I understood if patient requires higher oxygen. I think oxygen concentrator would be required in patients who are not able to get discharged, who are on 2 liters of oxygen or 3 liters of oxygen, are in the ward for 15 days, 20 days, 25 days. These are the people who can be sent home on oxygen concentrators. But in the acute day 5, day 6, day 7, probably concentrators were a myth. And as a result, many of the patients who were on oxygen concentrators at home, they deteriorated faster compared to those who were in the hospital. That is what my understanding was, Ullas.
So on that, Dr. Khilnani, sir, your final comments, and then I'll hand it back to the organizers.
No, but these are two different modes of delivery of oxygen. You can run a ventilator also on a cylinder. You can actually give very high pressure oxygen. The oxygen concentrator is basically meant for long-term oxygen therapy, classically given to the patient with COPD. We have done it for donkeys years, and they have a limitation. And there are certain makes of country which is making oxygen concentrator, which was totally farce. I should not name the country that, and everybody was. But lately the 10-liter concentrators also came. So they were pretty useful. If you are talking about 10 liters of oxygen per minute, then at least you will get 6 or 7. So they are not useless. The cylinder will, if you are giving high flow oxygen with cylinder, it will get empty. Even if the big cylinder will finish in 48 hours, where do you fill it up? So if you want to be doubly sure, so what people in Delhi did, that they kept both. I know it's hoarding is not good, but it was a question of life and death. People who had relatives, they were dispatching. So oxygen concentrator and cylinders should not be equated. Cylinder have a different kind of role, and concentrators are only meant for low flow oxygen.
Badira, Dr. Badira, you had a point to make?
Yeah, no, so as Sir said, I mean, there are 5 liter, there are portable oxygen and the other continuous electric supply oxygen concentrators. There are 10-liter concentrators also available. And some of, as Sir said, in the end, the amount that they deliver would be up to 6 to 7 liters. But some of them give a high concentration FOU2 also. So in the pandemic way, you really have a deficient supply of oxygen. They do help a lot, and especially in the weaning time, they make a lot of difference. And the portable, even though they say 5 liters, they give only up to 2 to 3 liters flow. So that transition period, the portable ones would be more beneficial. And during the admission severe period, I mean, in the period where you have deficiency, the 10-liter would make a bit of difference.
Ullas, I have a point here. Point. As Dr. Khilnani sir said, and as Badira said, I think there is no confusion regarding use of oxygen concentrator in a weaning phase or in a chronic period where a low sustained oxygen is required. But the 10 liters, what we saw in Delhi, at least I saw in Delhi in 10 different households on video. These were 2 5-liter cylinders, and they need to be connected through a connector. Connector was not available in Delhi. People had 10 liters oxygen concentrator. They did not have connector. They thought, do naak mein dalne se 10 liter ho jayega. We did not even know that 10 liter gave, 3 liters, 4 liters, 5 liters. As Dr. Khilnani sir mentioned, that we didn't know the make of concentrator. Yes. So I think oxygen cylinder, even though they got over in 24 to 48 hours, at least we knew that they are delivering what they are supposed to deliver.
Okay, Dr. Devatia, last point, and I'll hand it back to Dr. Purvish Parikh after that.
So just 2 quick points about the concentrator. Many of the concentrators, depending on which model you use, they cannot run continuously for 24 hours. You have to give a break in between for a short period of time. So sometimes it pays to have a small cylinder at the side or maybe another concentrator. But that's one. Secondly, they run on electricity, and there are some. Delhi, Mumbai, not a problem. In smaller towns,
Delhi is a problem. Delhi
is a big problem. It's as bad as not having a cylinder or any oxygen.
Okay, so that brings the end to my moderation of today and last time. And thank you. Thanks a lot to all my panelists for being a sport and answering all my doubts. And actually, we learned a lot from this. Thank you. And I hand it back to Dr. Parikh. Thank you.
Thank you very much, Ullas. As you rightly mentioned, this discussion was so vital and so interesting that Amish has graciously agreed to do it the next time. On coming Tuesday, when we have our next session, which is on 25th, the session is on breathing method and exercises during and after COVID. And this session is going to be taken by Dr. Parikh Mehta, who is a pulmonologist from Ahmedabad. And after that, again, we will have Dr. Amish Vora to continue with his a very important topic of anticoagulation, D-dimer, and problem of thrombosis in our patients. So once more, thank you very much, Dr. Ullas, Dr. Amish. Thank you all the panelists, especially the new stars that we have, Dr. White and Dr. Devatia. Both of you were a wonderful addition to what we discussed, and our senior ones like Dr. Kilnani, Dr. Nandita, Neil, Badira were excellent as usual. We also had some wonderful discussions from Dr. Navneet and Dr. Anil Singhvi and Dr. Sahoo. So stay safe, guys. We are still not out of the woods, and we will again meet you on coming Tuesday. Thank you.